It's a lecture review for Chapter 13 on psych disorders. As always, we start with our learning outcomes. The introduction for this material is what is abnormal behavior? So if you think about something, you might say, well, talking to yourself is abnormal behavior. But then we'd say, could that behavior ever be normal? So I know I talk to myself when I drive all the time. So who decides if a behavior is normal or abnormal? Really, we see that this is determined by the social or cultural context in which someone resides. There's also a matter of degree that's important. So if you wash your hands or check your doorknob 5 times a day, that might be perfectly normal. If you do this 50 times a day, then you might be skirting that abnormal line. So there's really a matter of degree in there. The explanation crazy. So this is something that we might see somebody and say, hey, their behavior is weird, unpredictable, they're crazy. But psychologists don't really use the term crazy or psycho. It's too simplistic, doesn't really tell us what's happening with someone's behavior. It also really feeds into the stigma surrounding mental illness, this idea of someone being crazy. So with stigma, what we're talking about is this feeling that people in society disapprove of you or your behavior. So it's this strong feeling of disapproval. We know that stigma is one of the biggest barriers to people seeking mental health treatment. So what is a psychological disorder? This will give a definition, but an important thing with psych disorders is we have to have certain criteria met for something to be considered a disorder. So it has to cause you distress, impair your ability to function, or both. So if you're perfectly happy with your behavior, you're not having any trouble with succeeding in your environment, then we wouldn't call that a psych disorder, even if we think it's something a little weird. Psychopathology. So with psychopathology, this is a field of study that you can be involved in if you're interested in this stuff, where people look at the origin, symptoms, and things of psych disorders. The DSM-5, this is something that's really, really important to understand, so I definitely encourage you to read this part of your textbook. But with the DSM-5, this is recently updated in 2013, and what it is a manual that gives a description of every psychological disorder. So it's written by the American Psychiatric Association, so it comes from that medical perspective. Many, many professionals helped to write this. And as this comic depicts, it's really, really important because in order for someone to be diagnosed with any sort of mental disorder, that disorder has to be outlined within the DSM. So if it's not in the DSM, it's not abnormal. The DSM has just description about a lot of different psych disorders. It tells you about the criteria, the risk. This is I put this in here so you can kind of see the categories present within the DSM, so some of these chapters. But obviously, because this book is so powerful, it is going to have a lot of critics. So some of the things that people complain about with the DSM is that it may include some cutoffs that are too normal. So especially surrounding grief, that it will have people maybe is seen as having grieving for too long, but maybe in society we'd say this is still normal. So can include some conditions that are normal. Some of these cutoffs are pretty arbitrary. So if you have symptoms for 4 months, you don't have the disorder, but if you have them for 6, then you do. So it can be a little arbitrary there. There's some concerns about gender bias against women. That maybe some of the disorders are oversimplified. And there's also some concerns about conflicts of interest. So some of the people who help to contribute to the DSM also work with pharmaceutical companies, so there's some concern there. The prevalence of psych disorders, we know that psych disorders are extremely common. So there's a high lifetime prevalence, high comorbidity. And what comorbidity means is having more than one psych disorder. So you have anxiety and depression, substance abuse, and a mood disorder. Most people receive or seek no treatment. So we know that this is in part due to stigma, but also due to lack of mental health care services. Our categories of psych disorders is where we're going to spend the rest of our time. We're going to start with anxiety. So anxiety disorders, kind of the hallmark of an anxiety disorder is this feeling of intense anxiety. So we all feel anxiety, but really disorder or anxiety disorders have this pathological anxiety. So it's maladaptive, it's uncontrollable. The first disorder we're going to talk about is generalized anxiety disorder. So with people who have GAD, their anxiety is global and persistent. So they might have one source of anxiety being a test, and then as soon as that test is complete, then the anxiety moves on to something else, a relationship, another test. So it's just free floating. To explain generalized anxiety disorder, we know it's really, really complex. There's a lot of factors underlying it. and it can be evident from a very early age. So we can see young children with GAD. Panic, people who have panic, it's another form of anxiety, but people who have panic attacks, if you've experienced one of these, you know that they're terrifying. So it's this feeling of your anxiety escalating. A lot of the symptoms are physical in nature, and many people believe that they're about to die or go crazy. So panic attacks will bring people into the hospital for fear of having a heart attack or something similar. People with panic disorder have many frequent and unexpected panic attacks. So to explain why people have panic disorder, there's a couple theories, but one of the major ideas is that people will be oversensitive to their physical sensations. So they'll have a change in their body, maybe their heart beats a little faster, their palms get sweaty. They'll misinterpret that as some kind of important physical symptom. So I'm having a heart attack. And that will bring on more feelings of fear and anxiety, which will further increase physical arousal. Phobias. Our phobias, this is a word that's really used commonly in our vernacular, and what we mean by phobia is this persistent or irrational fear of an object, a specific object. For many people, this will take the place of a specific phobia, so it's one particular thing that triggers that phobic feeling. There's a lot of categories of phobias. The most common are things like particular situations, such as driving, injury or blood, certain animals, but there can be a lot of unusual phobias as well, which this table depicts. Social phobia is extremely common. We also call this social anxiety disorder, and people with a social phobia have this irrational fear that people are going to judge them. So how do we explain our phobias? So we know that a lot of it has to do with learning. So things like classical and operant conditioning underlie our phobias, as well as observational learning, modeling the fears we see in other people. And some fears we think have an evolutionary history. So being afraid of snakes would have kept you alive. So that's maybe a reason why those are so common for people to have phobias. Post-traumatic stress disorder is another one of our anxiety disorders. PTSD will develop in response to trauma. Here's some of the core symptoms here, but really it involves recollection of events, having increased physical arousal. PTSD is more commonly developed in certain situations. So when people have a personal or family history of psych disorders, greater trauma magnitude, or multiple traumas. So first responders with 9/11 were much more likely to be diagnosed with PTSD than someone who responds to a simple one-car accident. So the greater trauma magnitude, more likely to be diagnosed. We also know that PTSD is more prevalent in women, and so this is kind of interesting because we first studied PTSD with combat vets, but we know that women are more likely to have a diagnosis of PTSD. Obsessive compulsive disorder, what this is having this anxiety basis, but we have certain thoughts that are intrusive and these urges to perform the behaviors. The obsessions are the thoughts and the compulsions are the behaviors. I would definitely encourage you to watch one of the videos linked down here. Howie Mandel's experience with OCD is really enlightening. This table will go over some of the most common obsessions and compulsions. To explain OCD, we know that it has a lot of neurochemical as well as brain implications, so dysfunctions in certain chemicals and brain areas. That'll bring us into our mood disorders. So our mood disorders, what a mood disorder is a serious or persistent disturbance in one's emotions. You can watch the crash course linked there. This quote's going to give someone's depiction of what it's like to live with major depression, so we can see through reading this quote that it's a lot more than simple sadness. The symptoms of major depression, what I want you to gain from this is that the symptoms are wide-reaching. So we have emotional, cognitive, physical, and behavioral symptoms. So it's a very, very system-wide kind of issue that people experience. It's physical as well as emotional. Another type of mood disorder is seasonal affective disorder. So people with seasonal affective disorder, their depression occurs in the fall and in the winter when there's the least amount of sunlight. Dysthymic disorder is similar to major depression, but just kind of at a chronic low level. So they feel those depressed feelings, but it's not severe enough to be major depression. An interesting thing with dysthymic disorder is this has to last for 2 years or longer. So a major depressive episode or major depression, you can get that diagnosis after 2 weeks. But for dysthymic disorder, it has to be 2 years. The prevalence of major depression has been called the common cold of psych illnesses because it's extremely prevalent. Women are twice as likely to be affected, and this gives some reasons for that, but untreated symptoms can last for a long time. Bipolar disorder is something we used to call manic depression, and with bipolar disorder, we have the mood shifts or the depressive episodes, but it alternates with periods of extreme mania or euphoria. So this will give a description of a manic episode, but includes things like flights of ideas, being really, really excited, or having a lot of energy. You can also see a milder form of bipolar disorder, which we call cyclothymic disorder. Interesting things about bipolar disorder to me that this slide will cover is that a lot of people believe that people with bipolar disorder have mood shifts that occur throughout the day. So they might experience 10 mood shifts a day. But we know that's not the case. So people are actually considered rapid cycling if they have 4 or more episodes a year. So to explain our mood disorders, we know there's a genetic predisposition and brain chemistry implicated, as well as stress. We won't spend a ton of time in eating disorders, but we know that eating disorders are these serious disturbances in eating behavior. Many people diagnosed with eating disorders are women, and people might eat too much or too little. We'll talk about anorexia as well as bulimia. So this will give some criteria for anorexia, but an important thing with anorexia is that people will have distorted perceptions. So they may be objectively very slender, but they see themselves as much larger. And the physical effects are similar to what we'd see with starvation. With bulimia, we have a pattern of binging and purging. And people with bulimia, they generally stay within a normal weight range, and they also don't have that same cognitive distortion. They know that they have an eating disorder. The causes of eating disorders are biological in nature, as well as some of the cultural and family attitudes. So this table will depict these 2 eating disorders, and that'll pull us into personality disorders. So this is a description of personality disorders. With this, we see this maladaptive pattern of kind of one's entire personality. And then we kind of say this deviates from our cultural expectations. There are multiple personality disorders, but we'll only talk about 2, antisocial and borderline. People with antisocial personality disorder, they often violate the rights of others with no remorse. So we might call these people sociopaths or psychopaths. This doesn't mean that they're always violent. Many people will have this diagnosis and not be violent towards others. But with kids, we can see this starting with what we call conduct disorders. They may be cruel to animals or people, set fires. And as adults, we really see a lot of deception and manipulation from these individuals. With borderline personality disorder, we call this the most serious and disabling personality disorder. It has a lot to do with feelings of impulsiveness or instability. But the reason why it's so disabling is because many people with BPD will engage in self-mutilation or actually commit suicide. So it's a very important, very disabling personality disorder. That'll move us into dissociative disorders. So most of us have had a dissociative experience where you just maybe get in the car, start driving, you end up at your destination and you have no idea how you got there. That's a dissociative experience. But dissociative disorders, we see extreme and frequent disruptions. So with dissociative amnesia, we have people who kind of have this inability to recall information, especially personal events, and this often follows some form of conflict. So a fight with a partner, and then somebody just can't remember anything about themselves anymore. Fugue is an interesting dissociative disorder because people with fugue will wander. So they'll have that amnesia, but then they might cross state lines and just wander. So I would definitely review that article there on the New York Times. From the New York Times, it goes over a case of this dissociative fugue. Dissociative identity disorder, we used to call this multiple personality disorder, but people with DID have memory disruptions as well as specific alters. So they'll have the presence of at least 2 different identities. And these alters will have their own name, history, and self-image. However, not all psychologists are convinced that DID is real. So there was a lot of cases that came on after we had more media coverage of DID. So not everyone's convinced that it is, but it is in the DSM, so it is a classifiable diagnosis. To explain DID, we think it is a form of coping. So you'll have people who've experienced extreme childhood abuse, and to cope, that child will then disassociate during that experience, which will eventually form a new alter. The problem is, obviously, this is very difficult to test, and for most people, the opposite actually happens. So instead of disassociating, they instead relive that experience, maybe developing more of a PTSD. And this graphic will go over our dissociative disorders. So we'll have another video linked to talk about schizophrenia, so definitely review that video as well.